I'm going to talk about scope of physiological pacing in day-to-day clinical practice. Physiological pacing essentially means capture of His-Purkinje system beyond the site of block, so that ventricular activation remains physiological through His-Purkinje system. Most importantly, this is important for the left ventricular activation. Now, a lot of data has come proving superiority of physiological pacing over RV pacing, but still we need to rationalize the use of conduction system pacing for our patients in day-to-day practice. The main reason is that whatever data we have for His bundle and left bundle branch pacing is a short-term data to medium-term data, and there is no randomized control trials available. That's why we need to understand in which subset of patients this is going to give the maximum benefit. The reason why right ventricular pacing creates problem is that it produces intraventricular and interventricular dyssynchrony, which leads to delayed activation of LV free wall. And this results into adverse LV remodeling, leading to LV enlargement and LV dysfunction. Pacing-induced cardiomyopathy incidence is not small. Depending on the definition used, the incidence can vary from 20 to 40% over a period of 3 to 4 years. And also, pacing-induced cardiomyopathy should be viewed as a spectrum. LV dysfunction just sits at the top of the iceberg. Tip of the iceberg, and you can still have adverse consequence despite preserving LV function because of the altered LV mechanics produced by RV pacing, like heart failure hospitalization and atrial fibrillation. The most important risk factor for pacing induced cardiomyopathy is a pacing burden. RV pacing more than 20% are the subgroup of patient who goes on to develop pacing induced cardiomyopathy. Also, extent of dyssynchrony that is imposed on LV is more when there is a baseline LV dysfunction. So, LV dysfunction in a patient requiring pacemaker is a very important risk factor for producing pacing-induced cardiomyopathy. Obviously, the pace QRS duration, the broader the QRS, more the dyssynchrony existent in that patient. So, these three are most important risk factor for pacing-induced cardiomyopathy. If you look at the studies which have compared His bundle and left bundle pacing versus right ventricular pacing, His bundle pacing and left bundle pacing both have shown significantly reduced mortality, heart failure hospitalization, and upgradation to biventricular pacing in a combined endpoint. This reduction was primarily driven by reduction in heart failure hospitalization. And when you compare the subset of patients where patients required more than 20% of RV pacing versus less than 20% of ventricular pacing, you can see the event rates differ in only those subset where RV pacing requirement is more than 20%. So this makes a case of using conduction system pacing in all those patients where requirement of ventricular pacing is going to be more than 20%. If we look at the data of block HF trial on the basis of which we recommend biventricular pacing in patients with heavy block and LV dysfunction, you can see that event rates curves goes parallel with the right ventricular pacing. That means the biventricular pacing has the same event rates as RV pacing, just that these events happen very late in the course compared to right ventricular pacing. So definitely BIV pacing is superior in this subset of patients, but it is not the ideal solution. If it would have been ideal, the line of biventricular pacing would be completely divergent to the RV pacing. So let us look at some clinical example. This is a 65-year-old female presents with effort intolerance, 2:1 AV block. echo is normal, and 24-hour Holter suggestive of AV block more than 90% of time. If you look at the ECG, there is 2:1 AV block. In the latest part, you can see 3:2 AV block with some slight PR prolongation happening. So this localizes the AV block at the nodal region, so above the His. So this patient was treated with the His bundle pacing, and if you look at this echo slide, you can see that His bundle pacing is located at the membranous septal region. Now, since His bundle pacing activates both ventricle through the His-Purkinje system, QRS complex remains essentially same as native QRS complex as seen here. This is a case of infrahisian AV block, very slow escape rhythm and wide escape rhythm, required urgent temporary pacing. And since the level of block is at the infrahisian level, we did a left bundle branch pacing. Now in left bundle branch pacing, as you see in this echo slide, you can see that the position of ventricular lead is in the muscular septum and the tip is just beneath the LV endocardium. Left bundle branch pacing activates LV through the His-Purkinje system, and that's why it produces RV delay pattern in lead V1, which is QR complex or right bundle branch complex in the lead V1. Importantly, LV activation time is very short as measured by stimulation to peak of QRS in lead V5 and lead V6. So LV activation time remains very short in left bundle branch pacing. These are certain uncommon indication of putting a pacemaker in a patient. This patient presents with effort intolerance and severe shortness of breath. PR interval was 400 milliseconds. Now, to establish this as a cause of patient symptoms, you need to look at the echo. If echo shows fused E and A wave with higher mitral inflow velocity and diastolic mitral regurgitation, this essentially tells that the symptoms are probably related to the prolonged PR interval. And obviously, you would not like to correct AV dyssynchrony by giving patient interventricular dyssynchrony. So obviously, in such patients, conduction system pacing remains the choice of approach. Another indication where I feel that conduction system pacing has a very important role and better than any other modality is a patient who undergoes AV junction ablation and a permanent pacemaker for rate control of AF. This is a case of young male underwent mitral valve replacement, recurrent hospitalization for heart failure and severe LV dysfunction. Failed rate and rhythm control by 3 different drugs, and then eventually he underwent left bundle branch pacing and AV node ablation. You can look at the ECG post ablation. There is a very sharp QR pattern in lead V1 and very short LV activation time. QRS duration is almost 108 milliseconds. This patient's LV function improves within 3 months of achieving rate control by AV junction ablation and pacemaker. Another important subsets are patients with LV dysfunction. These are block HF subgroup of patients. So this patient is a chronic AV block, ejection fraction 25%, multivessel disease, underwent CABG. And if you look at the ECG, this clearly establishes the AV block at the level of AV node. And we offered him a His bundle pacing, and you can see there is one A-sense V pace with ventricular complex, actually the same because of the selective His bundle pacing. Similarly, you can also offer left bundle branch pacing in patient who has LV dysfunction and AV block. So this patient underwent relatively young patient with class 3 symptoms and ejection fraction of 40%, undergoes left bundle branch pacing with a stillet driven lead. CRT upgrade is a standard of care in patients with pacing-induced cardiomyopathy. But is that the ideal solution? Probably no. CRT has done very well in this subset of patients. Majority of patients are super responder when you use it for pacing-induced cardiomyopathy. But still, the complication rates, patient event rates are significantly higher when you try to put additional leads and use a CRT upgrade. So in one of the national inpatient cohorts, CRT upgrade procedure was associated with higher rates of in-hospital mortality compared to de novo CRT. So CRT upgrade is not probably an ideal solution for PICM, though it remains the standard of care till now. Now there is a data that is emerging that His-Purkinje system does equally well in patients with pacing-induced cardiomyopathy, and this is one of the case. 68-year-old male, status post CABG, permanent AF and AV block, was treated with single chamber VVIR pacing. His ejection fraction dropped from 50% to 20% with heart failure symptoms of class 3, and he undergoes left bundle branch pacing, and you can see there is a nice QR pattern in lead V1, very short LV activation time. Also important to note that you have uncovered Q waves in inferior leads related to previous myocardial infarction. So this patient's LV recovered back to 50% after 3 months of follow-up. And the benefit of using conduction system pacing is that after 2 years of pacemaker implantation, you can still use the same pulse generator. Only thing required is just an addition of conduction system lead. Conduction system pacing, again, there is a lot of data now that has shown that it can be used in a patients where CRT is indicated. You can use it as an alternative to CRT in patients where LV lead parameters are suboptimal, or there is challenging CS anatomy where operator is not able to place the lead in a stable position in a posterolateral vein, or you can use it in lieu of LV lead as well. Probably some group of non-responder patients with conventional biventricular pacing can also benefit with conduction system pacing. This is one of the case where biventricular pacing was attempted in a patient with left bundle branch block, ejection fraction of 20%, NYHA class 3, and during struggle of putting a lead in tortuous posterolateral vein, there occurs a perforation of that vein, and also at the end coronary sinus dissection. Now this patient would go for epicardial LV implant previously, but now because of availability of conduction system pacing, we just place this lead in the His bundle, distal His bundle, and that could correct the left bundle branch block completely with very excellent parameters. So this patient, instead of using BIV device, we just ended up the procedure with a dual chamber device. And you can see the QRS complex from 160, it has become 90 milliseconds. This is another case where lead positioning was very easy. There was a large vein, so lead just went through in the posterolateral vein, but it would not capture LV reliably without phrenic nerve capture, despite using a quadripolar lead. So obviously, with this adverse LV lead parameters, we need something which can bail us out, and in this case, His bundle pacing bailed us out. If we can see this EP tracing, there is a nice His bundle potential, small a, very prominent V, and pacing from that side completely corrected left bundle branch block, and almost 180, 190 millisecond of QRS complex becomes to 90, 96 millisecond. This patient from LVEF of 25%, within 2 months, almost near normalization of ejection fraction to 55%. We don't need that difficulty in CS anatomy, difficulty in placing lead or LV adverse lead parameters. You can just go ahead and put a lead in a conduction system area. In this patient, QRS complex almost 200 milliseconds, severe LV dysfunction, and required ICD also because of the ill-sustained VT on Holter. Now, instead of using left bundle LV lead, we just placed a left bundle branch lead inside the muscular septum, and that narrowed down QRS complex from almost 190 to 200 millisecond to 108 millisecond. So with that, I would conclude that conduction system pacing is superior to right ventricular pacing across all pacing indication when significant ventricular pacing is required. This essentially leaves out indication for sinus node dysfunction, pure sinus node dysfunction as an indication for pacemaker. Conduction system pacing is non-inferior to biventricular pacing for CRT indications, and it is an excellent alternative for subset of patients with limitations for biventricular pacing. Both approaches are complementary to each other. You can use either conduction system pacing or bi-V pacing or combination of both to achieve the maximal outcome, because now we have that liberty with availability of conduction. Thank you.